70% of adults vaccinated with their first dose by the 4th of July. We've made incredible progress towards that goal. In fact, several states, including my home state of Washington, have already reached it. But nationally, we are still short. Only 65% of adults have received their first dose. And while the progress we've made so far is promising, it has not been consistent. Some states may have vaccinated over 70% of adults with one dose, but some have not even reached 50%. And even in states like mine, there are areas, especially in rural communities, that are falling behind. In some rural counties in our state, the rate of adults who are partially vaccinated is below 40%. We are also continuing to see huge inequities when it comes to the rate of vaccination, including in Black and Latino communities. It's so important that we keep pushing because as the rapid spread of the Delta variant in India is showing, this pandemic is not over and the threat it poses is still very real. The new Delta variant of COVID-19 is more contagious, more likely to send people to the hospital, and it is already here. Researchers in Washington State have identified 170 cases in my state, and the Centers for Disease Control and Prevention says it now accounts for 10% of COVID cases across the country. In the United Kingdom, the Delta variant has already delayed efforts to reopen and surged among youth aged 12 to 20. That should be a red flag, especially as CDC recently found even as cases across the country have been trending down, hospitalizations for adolescents due to COVID increased in April. We have to stop this pandemic. We need to do it soon, and we know vaccines are the best shot we have, which is why starting in January and February of 2020, I worked with then Chairman Alexander and other members of this committee to fund and scale up COVID-19 vaccination efforts throughout our response bills. Working together, we made historic investments that allowed experts to create a remarkable system to speed up the manufacturing and development of COVID-19 vaccines, and that I believe will be seen as the cornerstone of our efforts to beat COVID-19 here in the United States and around the world. Throughout our work, I also pushed to make sure we focused on how we distribute and administer vaccines quickly and equitably, and how we promote vaccine confidence and fight misinformation. And I'm pleased the Biden administration is prioritizing vaccination both domestically and internationally by providing millions of excess doses to fight this pandemic globally. We managed to administer over 200 million vaccines in the U.S. during President Biden's first 100 days in office. But in the past few weeks, our vaccination rate has dropped down to where it was in January, less than 1 million vaccinations a day. As remarkable as the last few months have been, everyone in this room knows, even with our system to develop, distribute, and deploy COVID-19 vaccines, we will not reach the goals in many states and communities if we do not continue to address the hesitancy, misinformation, and other issues holding back Americans from getting vaccinated. We have to continue increasing access and addressing barriers which make it hard for people to get vaccines, especially for people of color, people with disabilities, and people who live in rural areas. And as we tear down those barriers, we also have to tell people they can get vaccinated quickly, close to home, and at absolutely no cost. We're also still seeing an alarming number of people say they don't trust vaccines and don't intend to get vaccinated. People want to make the right decisions for their family's health, but too many people with genuine concerns are being misled by false information. We need to address the misinformation and make sure people with questions are getting reliable answers. Facts, science, and experts are a central part of that work, but encouraging people to get vaccinated is not just about getting the facts right, it is about trust. That's why we need to make sure we have messages that resonate with people and address their unique concerns delivered by messengers they know and trust. We need to work with healthcare providers as well as advocates and leaders from every background, people of different races and religions, different geographies and generations, and yes, even different political parties. So I'm glad we're having this bipartisan hearing today to talk with experts from different backgrounds about how we meet people where they are when it comes to trust in vaccines, what messages are most effective in reaching people, where people are getting their information, and who are the voices they trust the most. I hope our discussion will provide helpful answers to anyone listening who might have concerns about getting vaccinated themselves. people who are not sure how to productively discuss those issues with others in their life, and leaders and communities across the country. At the end of the day, we need people to understand choosing not to get vaccinated does not just put themselves at risk, it puts at risk the people around them, including people who are fighting cancer and are immunocompromised, and kids who are not yet eligible for vaccines. Getting vaccinated also doesn't just help you stay safe, it helps us get back to school and work and concerts and sport games and family gatherings without people having to fear getting sick with this virus, which has now killed over 600,000 people in this country. I look forward to hearing from our witnesses today. Thank you all for being with us. We want to hear from you about how we get these messages out, how we get vaccines in arms, and finally get through this pandemic. With that, I will turn over to Ranking Member Burr for his opening remarks.
Thank you, Madam Chairman. I'm glad we're able to hold this important hearing together today. The COVID-19 vaccine is the fastest way for our country to recover from this pandemic. We all have to do our part in encouraging Americans to take this safe and effective vaccine. I've experienced the hesitancy of some Americans to take the first shot firsthand with friends, family members, wondering whether the vaccine is safe enough for their families. The answer is absolutely yes. I got the vaccine, so did my wife, so did my children. When the FDA authorizes the vaccine for children under 12, I will encourage my children to vaccinate my grandchildren. The staff in this hearing room have gotten vaccinated. My Senate colleagues have either gotten vaccinated or had COVID themselves, which provides a natural immunity. Clinical trial data shows that Moderna and Pfizer vaccines are 100% effective in preventing hospitalization and death. And the Johnson & Johnson vaccine is 85% effective for preventing hospitalization and death from the virus. A year ago, when we were in the darkest days of the pandemic, I thought people would line up for miles to get a vaccine that kept you out of the hospital and prevented you from dying from COVID-19. I still believe that, which is why this hearing, I believe, is so important. We've experienced much loss in this country over the last year, and now we have a tool, the vaccine, to end this and to return to normal. Let's use it. The efforts of Operation Warp Speed brought our country and the world 3 vaccines to protect against COVID. They're safe and they're effective. Operation Warp Speed is a testament to American innovation and ingenuity and shows that the framework we designed in the statute actually worked. The vaccines we have for COVID are safe and they do work. Pfizer's 95% effective, Moderna's 94% effective, Johnson & Johnson 67% effective in preventing COVID-19. Today, over 177 million people have received at least 1 dose. 55% of adults in America are fully vaccinated. Over 87% of seniors, those most vulnerable to the effects of the virus, have received at least 1 dose of the shot. At least 10% of the Americans have had COVID-19, so there's also a number of people who have some natural immunity to the virus. Even with all this progress, there's so much more work to be done. I said during our last COVID-19 task force hearing with the administration that we would reach a point where we have more shots than we do arms. This moment has arrived in the United States, and we cannot be complacent. Israel showed us the roadmap for what to expect, where vaccination rates began to level off as roughly 60% of the population became vaccinated. Reports out of India and the UK of the Delta variant are evidence of the importance of protecting Americans now and encouraging everyone who still needs to get vaccinated to get it. The number of doses administered in the United States per day is falling. Earlier this month, the rate dropped below 1 million doses per day for the first time since January. That's compared to a peak of 3.3 million doses per day in April. Of the 328 million Americans, almost 284 are 12 or older, making them eligible today for a vaccine. Nearly 177 million people so far have received at least 1 dose, which means about 106 million are still eligible. Clearly, we still have a lot of ways to go to get all eligible people vaccinated and put this pandemic firmly behind us. We also cannot forget about the importance of global health security. If we do not help other countries access the vaccine, we'll not see the end of the pandemic. The way to help other countries access vaccines is to protect against COVID-19 is through the extremely successful public-private partnerships that have developed and manufactured the vaccines we have today. As I've said before, removing the intellectual property protection only ensures that we don't have the vaccines we need when the next pandemic occurs. Americans that have not yet gotten the COVID-19 vaccine need to know the benefits that come along with it. The most compelling case to me is that the shot keeps you out of the hospital. It also gets you back to work and helps keep people who you work with safe. Senator Kaine, he's not here this morning, said at the last hearing earlier this year that he wore a mask so the grocery clerks felt safe. Getting a vaccination helps keep you safe. It helps keep your family safe, and it keeps those around you safe. It also helps Americans return to the things they enjoy, like concerts, movies, baseball games, or watching the Panthers in Charlotte play. Over the next few months, important outreach efforts will continue to focus on younger people. Schools are reopening in the fall, and one of the vaccines is already available for children 12 and up. In-person learning is critical, and our efforts over the summer should be to focus on getting kids the shot, protecting them from the virus. As a grandparent, I look forward to the day when the vaccine is available to young children as well. I'm pleased to have representatives from Sesame Street here today to talk about the information families need as we prepare for that round of vaccinations. Our efforts should be focused on reaching communities that have questions. I look forward to hearing from each of our witnesses today about the partnerships and programs that you have underway to meet America where they are, answer questions, dispel myths about safe and effective vaccines, and get more shots in arms. Before I yield back, Madam Chairman, let me just say, it's hard for me to believe that the best example of innovation in this country seems to be the thing that makes individuals hesitant about being vaccinated. It happened too quickly. Well, let me assure my colleagues, let me assure the American people what I think the witnesses know. These vaccines went through the most exhaustive clinical trials of any medication that we've ever approved for this market. We haven't shortcut anything in any area of government, but we did set up a pathway for accelerated consideration that was taken advantage of, and as I think Dr. Cassidy would agree, it's the science that you follow. And when the clinical trials come back and prove safe and effective, then you should feel comfortable taking this vaccine. I thank the chair.
Thank you so much, Senator Burr. With that, we will now introduce today's witnesses. Start with Dr. Susan Bailey. She's a pediatric allergist and immunologist from Fort Worth, Texas, a distinguished fellow of the American College of Allergy, Asthma, and Immunology, and she recently finished her tenure as president of the American Medical Association. Dr. Bailey, thank you for joining us today. Our next witness is Dr. Michelle Nichols. Dr. Nichols is an associate professor of family medicine and associate dean of clinical affairs at Morehouse School of Medicine. She has led the historically Black university's community vaccination efforts and research focused on community engagement, health disparities, preventive health, and COVID-19. Thank you for joining us today, Dr. Nichols. With that, I'm going to turn it over to Senator Burr to introduce our next witness, Curtis Chang.
Thank you, Madam Chairman. As the son of a minister, I am privileged to be able to do this. Mr. Chang is the co-founder of Christians in the Vaccine, a group that aims to promote vaccine confidence among evangelical Christians. To conduct this outreach, Christians in the Vaccine has partnered with the Ad Council, National Association of Evangelicals, COVID Collaborative, and the Values Partnership. In addition to his faculty appointment at Duke Divinity School, Mr. Chang is a senior fellow at the Fuller Theological Seminary. His ministry experience includes serving as senior pastor of an evangelical covenant church in California and is a campus minister with the InterVarsity Christian Fellowship. He's also done mission work in South Africa and is the founder of an award-winning nonprofit consulting firm. Mr. Chang earned his bachelor's degree at Harvard University and is a former Rockefeller Fellow. Mr. Chang, thank you for being here with us today.
Thank you. And finally, our last witness is brought to us by the letter S for Sesame Street. Dr. Jeanette Betancourt is the Senior Vice President for U.S. Social Impact at Sesame Workshop. She is a licensed bilingual education therapist and leads Sesame Street's community initiatives to improve the health and well-being of children and families. Dr. Betancourt, thank you for joining us today. With that, we will begin our testimony with Dr. Bailey.
Good morning, Chair Murray, Ranking Member Burr, and members of the committee. The American Medical Association commends you for holding this hearing today, and I thank you for the opportunity to testify. I'm Dr. Susan Bailey, and I'm the immediate past president of the American Medical Association. I'm also a practicing allergist immunologist in Fort Worth, Texas, and those two roles have given me a unique perspective on the COVID-19 pandemic and its impact on our patients, on our physician community, and on our nation's health. COVID-19 is a watershed moment in our nation's history. It's both an epic tragedy and one of the greatest scientific achievements in our lifetimes, thanks to the courageous efforts of physicians, nurses, scientists, researchers, and the tireless efforts of so many working in government. The AMA has been committed from the beginning of the pandemic to making sure that physicians have the information and the resources they need to take care of COVID patients, to keep their offices safe, and to answer all of the questions that patients and physicians have about COVID-19 vaccine development. COVID-19 remains a very serious threat for certain high-risk groups and for those that haven't been vaccinated. But much has changed in the last few months to give us hope that the worst of the pandemic may be behind us. The good news, and I think it's good news, that more than 55% of adults are fully vaccinated and 65% have received at least one vaccine shot. And while there are racial and ethnic differences in vaccination, as well as regional differences, attitudes are shifting in most groups. To maintain this momentum, however, and finally bring an end to this pandemic, we need to work to get as many people as possible vaccinated against this virus. Many individuals are hesitant to receive the shot for personal, religious, or political reasons. The speed with which the vaccines have been developed and the politicization of the pandemic has naturally led to concern among the public about safety and efficacy. Physicians play a critical role as vaccine ambassadors for our patients. Experience has shown us that our patients place great faith in a strong, positive recommendation from their physicians, and that the information and education provided by physicians and other healthcare professionals results in higher vaccine acceptance rates. So the responsibility falls to us to answer their questions honestly, to address their concerns, and to be firm in encouraging them to receive the vaccine. This is our surest way through the pandemic. Regardless of the reason, though, we need to engage these vaccine-hesitant individuals and find ways to reach a common understanding of why these vaccines are important and safe, not only for the health of individuals and their families, but for the health of our country. We have to lead with the science. To do this well, physicians need to be part empathetic counselors, part research scientists, and part mythbusters. Obviously, our messages may differ depending on the reason for our patients' hesitancy or refusal. But that personal relationship and trust, built in many cases over years, can make all the difference. So that's why we have advocated for distributing the vaccines to physicians' offices. It's a lot easier to get shots in arms when your patients are actually in your office and the vaccines are in your office. And we're also working with partners, including the Ad Council and the COVID Collaborative, which are leading a massive communications effort to educate the American public and build confidence around COVID-19 vaccines. We have a lot more work to do to convince as many people as possible to get vaccinated. It will take all of us working together. Thank you, and I look forward to answering your questions.
Thank you very much. Dr. Nichols.
Good morning. Chairwoman Murray, Ranking Member Burr, and members of the Committee on Health, Education, Labor, and Pensions. Thank you very much for convening this important hearing on vaccines, America's shot in ending COVID-19 pandemic. I am Dr. Michelle Nichols, and I am presenting testimony on behalf of Morehouse School of Medicine, and I bring you greetings from President and Dean Dr. Valerie Montgomery Rice. I am a family physician, and I am the medical director of our COVID-19 community vaccination program, as well as the Associate Dean for Clinical Affairs. According to the CDC, the COVID-19 pandemic has brought social and racial injustice and inequity to the forefront of public health, and that has applied to vaccines as well. We were an early adopter in becoming a COVID-19 community vaccine provider. Based on our commitment to health equity and being a trusted entity within the African American community in both healthcare and research, we knew that we must tackle the hesitancy, mistrust, misinformation, and myths we knew that we had to do to tackle this virus. When vaccinations were first offered to the 75 years and older population in early January, we did a kickoff event and invited legendary civil rights leaders to become vaccinated because we wanted to build confidence and trust in the community. As we were vaccinating, we were concurrently doing educational programs, doing weekly town halls, panel discussions, and community outreach programs. Lessons learned from our first couple of months of the vaccinations led us to applying for and receiving grant funding to reach beyond Atlanta, Georgia, via our traveling vaccination mobile program. Since we are a trusted entity within the communities of color, over 75% of our vaccine recipients have been African American, compared to only approximately 9.9% nationally based on yesterday's CDC data. To help expand vaccinations in our Hispanic community, we started engaging and partnering with Latinx organizations and the consulate, and particularly the Mexican consulate, because patients tend to trust people who look like them, talk like them, and have similar backgrounds and education and experiences, which resulted in our current Latinx vaccination rate being 13%, which has positively impacted the Hispanic population vaccination rate in Georgia. At Morehouse School of Medicine, with our community outreach and focus on decreasing health disparities, vaccinations for Black and brown people and communities of color represent approximately 88% of our vaccinations. Lessons learned over the last 6 months are to impact trust by engaging the community and being part of the community, as well as having vaccinators who look like, sound like, and have similar experiences. Also providing information and education to dispel myths and misinformation, and to educate and make sure that that material is multilingual, also multimedia, and also with the appropriate educational level. And to meet people where they are in their vaccine journey, and to know that we are ready to vaccinate whenever they are. As far as our adolescents, we want to engage and educate both the parents and the children and plan back-to-school vaccine events with incentives such as book bags and supplies, and at the same time doing school physicals, preventive health reviews, and health checks. And when people come to get tested for COVID-19, we need to vaccinate them at the same time. We need to travel where the vaccine recipients are and make it as convenient as possible. And finally, we do not want to politicize this. We need to stay focused on the goal and educate and meet people where they are in their vaccine journey. Thank you for the opportunity to share our views with you. I am pleased to respond to any questions. Thank you.
Thank you. Mr. Chang.
Senators, the road to ending the pandemic runs through the evangelical church, especially the white evangelical church. At the national level, white evangelicals comprise the single largest vaccine-hesitant demographic in the country, with almost half signaling that they will not get vaccinated. At the state level, if you took a map of the least vaccinated states, it corresponds very tightly to a map of the Bible Belt, with some states not reaching even 1/3 of vaccination rates. And at the global level, American evangelical culture is highly influential in parts of Asia and Africa. We're already exporting our misinformation and fears to the rest of the world, especially via social media. Reaching every demographic in our country matters, but we are not ending the pandemic unless we convince more white evangelicals to get vaccinated. And this is why I, along with Chris Carter, who's here today, founded Christians and the Vaccine. It's a partnership with the Ad Council, COVID Collaborative, the National Association of Evangelicals and Values Partnerships, and we've produced and distributed a range of online video content to equip the evangelical community to address vaccine hesitancy in our own community. Why are white evangelicals so hesitant? Well, vaccine trust is essentially a proxy for institutional trust. Every one of us only takes the vaccine to the extent we trust the FDA, the CDC, pharmaceutical companies, and public health. Unfortunately, the level of distrust among white evangelicals with large institutions is at an all-time high. Now, there's complex and longstanding reasons for this growing distrust. Our own community's vulnerability to misinformation is certainly a big factor. But in the context of the vaccine, this tendency towards distrust has been exacerbated by public health's inattention and overlooking this particular community. While there's been hand-wringing about evangelical attitudes in the mainline media, there has been little targeted outreach from public health. As one state health official admitted to us, she said, we've spent maybe 2 minutes thinking about white evangelicals. To the extent that the public health has engaged with faith communities, it has overwhelmingly been with minority faith communities, where it has succeeded with remarkable effect, driving a 10-point jump in vaccine acceptance among Black Protestants in just a few months of outreach. Now, this racial equity emphasis has been absolutely necessary, given historical inequities and current barriers of access. However, this focus has not been matched by attention to the largest and most vaccine-hesitant community. And this inattention is simply counterproductive in a national pandemic where we're all connected. As a person of color, I need public health to focus on white evangelicals because what they decide affects my community. As our work has gained prominence, we did have the opportunity to speak with several key national public health institutions, all of whom showed great interest. However, they had no available pathway to partner with us to expand our efforts. Again, a key reason given was the fact that our focus did not fit the minority-focused communities. Another issue was that the vast majority of federal funding on vaccine outreach simply gets distributed to state public health agencies, meaning there's no efficient pathway for the federal government to partner with us on a coordinated national outreach. But it's not too late. It's not too late to persuade the white evangelical community. Faith-based efforts do work, as demonstrated by the success reaching Black Christians. And one very recent study by PRRI showed that 44% of vaccine-hesitant evangelicals say that they would still be influenced by faith-based efforts. The key recipe is a partnership between public health and faith leaders in the evangelical community. The message and the voice have to come from the faith leaders themselves because they're the trusted voices. But public health can make a big difference by convening the faith leaders, by providing resources to amplify their voices, and then especially by taking cues from those faith leaders on which public health efforts will work in their communities. The last point about taking cues from faith leaders is critical because there is no one-size-fits-all approach. For instance, what works in the Black church, such as having churches host vaccination sites, often does not work in the white evangelical church context. So I respectfully submit the following 2 requests to this committee for consideration. First, please consider supplementing the current state-focused approach with additional resources on national coordinated outreach. A state-by-state approach may be effective in some health issues, but in a pandemic, we need coordination. And then finally, please direct federal outreach to pay attention to white evangelicals. This community requires a specific type of outreach, and failure to do so puts all communities at risk.
Thank you very much. Dr. Betancourt.
Thank you very much. Thank you, Senator Murray, Senator Burr, and all of the committee in terms of help. First of all, what I'd love to do is introduce our process that we've engaged in throughout the pandemic, because one of the things I'm hoping to leave you with is the idea of looking at young children's perspective along with parenting. At Sesame Workshop, which is the nonprofit global organization whose mission is to help all children grow smarter, stronger, and kinder, we continually, not only through our programming, but through our social impact work, tackle the toughest topics. We've dealt with parental addiction, foster care, family homelessness. And throughout the process of the pandemic, we've actually structured this to meet the stages that families and children are engaged in throughout the pandemic. When the pandemic first hit, we called that stage the "for now" normal. Suddenly, young children and their families were in shelter in place. All the safety routines that are so typical for young children were lost. They no longer had the physical contact and routines that they generally have. The next stage that we are in now is the different, but before normal. In other words, we're transitioning back, but it's in steps. And additionally, we are preparing children to adjust along with their families to those steps. However, they've had quite a bit of crisis. It is the focus on our young children's and their families' mental health that we need to look at as we're making decisions around vaccination as well. We also look at our third stage as long-term consequences. What is the mental health of now this young COVID generation? So tying all those pieces together, now we have also partnered, like many of the colleagues here, with the Ad Council and the COVID Collaborative around messaging on improving and informing parents with young children that they should be vaccinated. There, the approach that we took is, how do you return to those safety moments, those things that you've missed before, that relevance to family life, and also the relevance to young children's well-being in their safety routines. In addition to that, we created all of these resources bilingually in English and Spanish in different formats, not only in terms of video, audio, and also digital resources that can be posted, whether it is posters specific for the Latinx community or the African American Black community or the immigrant community. Again, using the trusted power of our Muppets as a trusted source for parents and caregivers and children. Now, as we're reaching this next vital stage, we believe very strongly of the idea of creating a circle of care, a circle of safety when we get to the stage of now encouraging parents to vaccinate their young children. But I also ask you to look at the way we've messaged thus far. Our role many times is, how do we message in a friendly way for children and families and the adults who influence them so that they are making the decisions for the well-being of their children? However, throughout the pandemic, and rightly so, we've mentioned that young children are the least influenced or impacted by the pandemic. Again, it's not adverse, it is true. They're also very much likely the first to have returned to, quote, school, early childhood programs, whether it's through family, friend, and neighbor care, through center-based programs, or family child care. So from a parent's point of view, children, young children, especially below 5, are okay. The decision on vaccination will be a little harder, because along the way, they've been sort of told they're doing okay. It's the priority on children, on youth, and adults. So we are here to work with all of you, to partner, to also continue our messaging. And we believe that the next stage of convincing young parents in terms of vaccinating their young children is the idea of forming a circle of safety. I do it, my family does it, I include my children, but also the idea of bringing back those valuable routines to young children's well-being, in which all of us as a nation should be invested in. Thank you very much for this opportunity, and I look forward to your questions.
Thank you very much to all of our witnesses. We really appreciate your testimony this morning and find it invaluable, so thank you. Yeah.
That we have actually a PSA. I could not forget that. Okay. So we have, sorry, I bring my Elmo friend and also a PSA that we wanted to demonstrate. So sorry, demonstrate how we have messaged. And this is Elmo and his daddy looking ahead.
And I are feeling hopeful and excited.
Woohoo! Elmo can't wait to have an indoor play date with Abby.
We're excited because lots of grown-ups are getting the COVID-19 vaccine. Soon lots of us will be able to do our favorite things again.
It's really why he got vaccinated, and it's that hope for the future and return
Oh
to
yeah,
routines.
I can't wait.
I'm so sorry.
I got the COVID-19
I think all of us
vaccine.
probably know
So
what they're saying
me
just
and
by
my
having
family,
the
Yes,
question.
neighbors,
and you can imagine, yes, children's curiosity.
Thank you. There we go.
Oh, what's that, son?
Visit Nana. Yes, Elmo misses her so much. Elmo can't wait to give her this card.
Oh, she's gonna love that, Elmo. With Nana getting the vaccine, Elmo, Mommy, and Daddy can see her again soon.
Yeah.
With free COVID-19 vaccines, sunnier days are ahead. Visit getvaccineanswers.org.
Thank you.
Thank you so much. As a former preschool teacher, I now feel I can start my day. Thank you. We will now begin a round of 5-minute questions of our witnesses, and I ask all of our colleagues to please keep track of your clock, stay within those 5 minutes. Let me start. We know that the best way to reach people and address their concerns about vaccines is to actually tailor the message to their specific background and concerns. We also know the same kind of outreach won't work for everyone. Different communities may prefer to receive information in different settings, different messengers. Let me start with Dr. Nichols and Mr. Chang. You frequently talk to people who have not received COVID-19 vaccines. What are effective ways to customize outreach on vaccines to the person or community at hand? Dr. Nichols, let me start with you.
Thank you for the question. So I'm a family physician. So one of the things that I do is I started back in January of modeling and telling people that I had completed my vaccine series, and I told them what the effects were. The other thing is I always say, reach people where they are in their journey. So if people are hesitant, I give them the information, I give them the data, I give them the science to say that these vaccines are safe. Also, it's important to go where they are. So I go to their locations. I have actually gone to the various communities and had conversations with them. Now opening up to a sense of normalcy, I also went to, I did Zoom presentations. So also when I go toward my adolescents and my younger people, I talk to them about the importance of getting back to normalcy, of going back to playing their sports events, not worrying if they're going to be quarantined because some member of the team now has COVID-19. So I talk about that. I talk to parents about the opportunity so that their kids can get back to school and learn, because we all know that what happened was that we often saw that our kids were far behind. They were getting behind. And so I said, let's do what we can to get it back to normalcy. When I talk to my patients, I say, let's try, don't you look for the opportunity that you can now hug your grandkids? I have a lot of older patients. So I said, don't you wish that you had the opportunity to hug your grandkids? I say the same thing to my patients about seeing their parents. I was able to see my parents for the first time in February, and I was very thrilled to have the opportunity of seeing them in over a year, and they're in their 80s. So I talk to people about those things in those family gatherings. So I talk to people about what's important to them. And finally, one of the things that I did that was very important is that we engage people who look like and talk like them. Because I found that in our other communities, that if you had someone who was similar to you, this helped. When we looked at some of our other immigrants, such as those that were from Ecuador and different people, we found out that that Spanish nor English were the right language for them. And so we did videos that were in the Mayan language so that you can reach and help people to understand. So that's the important thing, just meet people where they are. And if they're not ready, I said, that's okay, because I'm here and we're here to vaccinate you whenever you are ready. Thank you for your question.
Mr. Chang?
I think given that there's institutional mistrust, the key is providing information and content to friends and family who vaccine hesitant folks will trust, people in their own social networks. And this is why we created short shareable videos to put in the hands of evangelicals to share with their neighbors, fellow church members, friends and family, and so forth. And the key here, I think, is actually social media, because in the pandemic, how we all are sharing and influencing each other is significantly mediated through social media. And this is where I would encourage efforts by the government to fund more outreach through social media, through generating content, through targeted advertising, because that is the battlefield right now for the vaccine trust efforts.
Thank you very much. Many of you mentioned misinformation in your testimony and the concern about that. These efforts seem to be growing and undermining all of your work and our work. We hear about constituents who are getting misinformation or spreading false information via Facebook, Twitter, other platforms. Let me just quickly ask Dr. Bailey and Dr. Betancourt, what would you tell all of us that we should be doing to stop the spread of false and misleading information on these platforms? Dr. Bailey?
Social media is certainly a double-edged sword. It can be a great venue for spreading good information, but also spreading misinformation. The AMA believes that social media networks need to have some responsibility for spreading false information that they know not to be true. And we need to be able to counter that with factual information from trusted sources, as my colleagues have said. If we completely bow out of social media and don't participate, then we are ceding that territory to those who are willing to spread misinformation. And I think it's important to understand that folks that are spreading misinformation are often doing so because they may have a book to sell, they may have a site they want you to go see, they may have something that they're trying to build up, and so it might not necessarily be in your best interest that this misinformation is being spread. I think it's important to know the source and to go to trusted sources.
Thank you, Dr. Betancourt.
Thank you for the opportunity. I would say that for our role, it's not directly dealing with misinformation, but how do we provide information that's relevant, valued, research-based for parents, caregivers, and we do so because we do incredible amount of research in the way we are messaging. Our hope is that we are counteracting that misinformation. But the other factor is, how do we deliver this information so that's relevant to the everyday moments of families and children, that it's also relevant to the key influencers in their lives, whether it's the healthcare community, the social work community, the early childhood community. The other way that we address as a trusted source now over 50 years is, how do we use, and the reaction that you had, our trusted Muppets, and again presenting from the child's perspective. Often because this is viewed as such a grown-up issue, we lose the fact of how our young children can be advocates as well. And that means looking at young children, having information on what helps them keep safe, on what helps their parents keep safe, and how we can do that collectively.
Thank you very much. I'm well over my time. I'll turn it over to Senator Burr.
Thank you, Madam Chairman. It's so remarkable to me that our whole national campaign from the start and continues today is all about TB. The only thing consistent with 30 years ago is Sesame Street. So it is a tremendous avenue for a particular population. The rest of America tunes out ads. I don't care if they're on COVID or something else. And it's remarkable how much money we've injected into this. But where we've seen success, Dr. Nichols, is when you've gone into those African-American churches. Ms. Chang, when you've focused on white evangelicals. Dr. Bailey, when you've said the family doctor the physician, we totally took out of the loop. Some of the reasons were the unique requirements for vaccines, and we really didn't have an explosion in vaccinations until we actually penetrated the retail pharmacies. So here's my question, Dr. Bell, just real quick. How much of the challenges behind vaccination is transportation?
Transportation of the vaccine is a challenge. Transportation of patients is a challenge. The initial phase of our mass vaccination efforts were to bring patients to the vaccines. That phase is over, and we knew that it wouldn't last forever. We knew that there was a lot of pent-up demand, but now that patients that have been wanting to be vaccinated are vaccinated. Now we are reaching individuals that are more hesitant. Many don't have transportation. Many may have transportation, but it's limited. It's been said that over 90% of Americans have vaccines available within 5 miles of their home. But that leaves 10% out, and 5 miles can be a long way if you don't have a vehicle and if you have to walk.
It's a long walk. Mr. Chang, should we have anticipated the white evangelical resistance?
Absolutely. The reason we started this campaign as early as end of December, even before vaccines were released, was because I think the masking controversy told us where this was headed, that of common sense public health effort got politicized, got polarized, got used by folks trying to gain attention and hearing to divide our country and our evangelical community. And we saw that the same thing was likely going to happen with the vaccine. And so I would say that overall, from where I sit, the public health efforts have been amazing in terms of the logistics and the development of the vaccine. It has been slow and a little bit late in messaging. And that's where I would encourage for the rest of this campaign and for future public health efforts to prioritize messaging as important of an investment to make as you do in the research and development of the actual vaccine itself, because a vaccine sitting on a shelf is not doing any good to anyone.
Dr. Benacourt, I commend what you guys have done, and more importantly, the fact that you're thinking in the future, because we will be in a situation where we vaccinate 1 to 12-year-olds. I'm convinced of it. We've got to.
Yes.
I'm more curious about how in your organization in the workshop, you addressed this change in the life of young people in the country. They no longer saw their grandparents. They no longer went to school. They no longer could go play with a friend. How did the workshop try to present that to this population?
It was really, we're very nimble, and we took advantage of taking the perspective of our child development and also parenting information, and we actually addressed it in phases. The first phase that we called was the For Now Normal, and bringing 2 factors. How do you normalize something that's now totally changed? And so we helped parents establish routines while still working and learning from home. We also started to bring the factor of joy and hopefulness, because suddenly everything was shut down. And from a parent, and especially a child's point of view, I no longer get to see my grandparents, my friends, and suddenly all of those connections are lost. So we use the power of our trusted Muppets in different ways, not only through our programming, but what we also do, like my colleagues here, is work with national and local partnerships to integrate these resources. So as they are connecting in the community, we are so doing as well. Last one is really the second phase that we are now. It's the different, but before normal. And we love these terms because they're very practical. They sort of reflect the stage that we're in. How do you adjust to what were before routines but are now very different in certain circumstances? We use animation, we use interactives, we use what we call printables, posters, to deliver consistent messages that fit into everyday moments.
Well, what I've learned is that kids are quite resilient, and adults very very non-resilient. But let me just say, everything that you guys have shared with us is important. And the challenge is, for me, why aren't we doing it all? Why aren't we in every black church that we can find on Sunday with somebody with vaccines and needles? Why aren't we in white evangelical churches? Why aren't we, promoting as much to the generational mix out there? Why haven't we got the full complement of doctors with vaccines in their office ready to inoculate folks? And I might add, why aren't we pushing the envelope and trying to figure out how to do microneedle patches where we're not reliant on a nurse that comes in and draws a vaccine, sticks you in the arm, where you could sit at church and pop these on people's arms, and for 72 hours they get their first dose, and then they come back and get a second dose. From a technology standpoint, that's available to us. But the bandwidth of how much can you do at the same time as you're innovating, we've also got to look at the communications and the parallel delivery systems if we want to capture as much as we can. Thank you, Madam Chairman.
Thank you. Senator Hassan.
Well, thank you, Madam Chair and Ranking Member Burr, and to all of our witnesses, thank you so much, not only for being here today, but for what you do every day. Dr. Nichols, I want to start with a question for you. As you know, Congress has provided funding to ensure that COVID-19 vaccines are available to all individuals at no cost. However, there remains a perception among some that they will be required to pay a copay or they're going to receive a bill if they go get the vaccine. What can we be doing at the federal level to ensure that people know that the COVID-19 vaccine is available at no cost?
Thank you for your question. So one of the things is I think that message is starting to get out is to do ads that say, go for your free COVID-19 vaccine. And so another thing, so that is the important thing, is just keep emphasizing the word that this is free.
Yeah.
So the other things besides, social media is just overwhelming.
Yeah.
And so that is, again, where you have to go into social media and keep emphasizing those words, that there is no cost to this, that this is our gift to you. Because so many people have lost loved ones. And so let people know that our gift, we're giving you a free vaccine.
Well, thank you. I want to follow up, too, on a point that Senator Burr began to make, because for many, there are related financial barriers associated with taking the vaccine. We talked about transportation a couple of minutes ago. There's childcare expenses, and some people are concerned if they have a reaction to the vaccine, there might be lost wages involved. So how do we most effectively acknowledge and work to address these barriers so that they don't limit the ability of individuals and families to access COVID-19 vaccines?
So one of the things that is important is for employers to give people the opportunity to stress the importance that you get, if you have a side effects, that we give you both, one, the time to go and get your vaccine,
right,
and number two, that we give you the opportunity that if you are having side effects, that is a paid leave, that you have the opportunity to be paid. So that is important. So if we're going toward mandatory requirements, which many employers are doing, that those are things that you must do. So I think, again, it's just getting the word out through whatever means necessary to let us know that we are going to support you and also your child care issues and your transportation.
Anecdotally, I am hearing, for instance, from some workers in long-term care facilities that they don't want to risk losing wages. When you're living paycheck to paycheck, this is a real issue. So thank you for that answer. I want to follow up to both Professor Chang and Dr. Nichols. We've talked a little bit about this. You both have learned from your work and the work of countless individuals across the country that the most effective way to improve trust in the vaccines is to meet people where they are. You've used that term several times, and engage respectfully about the safety and effectiveness of these vaccines. So the American Rescue Plan included funding to expand access to COVID-19 vaccines. So is there anything that you haven't said about how you believe we can effectively use these resources to continue and expand on your work? Just talk a little bit about what specifically you think we could use, the federal government could be using these dollars to do.
Yeah, I'll repeat again that I think the fact that much of these faith-based outreach has been directed to minority communities, which again is critical.
Right.
But I would encourage you to redirect some of that attention and resources to the white evangelical community. And then secondly, I do think the fact that the general channeling of these resources to the state level is proving to be ineffective to reaching this this particular community. I think a national outreach coordinated at a national level will be your most effective, bang for their buck here.
Okay. Dr. Nichols, anything to add to that?
I echo what Dr. Chain said, that what you really want to do is a national outreach to make sure that, and like I said, do not politicize this.
Yeah.
That is the important key, is that we are all working towards the same goal of decreasing deaths, decreasing hospitalization, and getting our world back to normalcy again.
Thank you. Dr. Bailey, I want to turn to kind of a related topic, but as you know, we've seen a concerning drop in routine pediatric vaccinations during the COVID-19 pandemic. A year ago, I sent a letter to the CDC requesting that they provide additional support to states and healthcare workers in order to reverse this trend. And while progress is being made, many children remain behind on their routine vaccination schedule. So how do we work to catch children up on routine vaccinations?
Agree. This is incredibly important that we get our children up to speed on vaccinations. And there have now been advisories issued that COVID vaccines can be given at the same time as routine childhood vaccines. And so I think that will be very helpful in trying to get as much done in as short a period of time as possible.
Okay. Thank you. Thank you, Madam Chair.
Thank you. Senator Marshall.
So thank you, Madam Chair and Ranking Member. My first question would be for Dr. Nichols. Dr. Nichols, one of my biggest frustrations was that we had a system in place where we would give 3 million flu vaccinations a day across this country, and that system consisted of community pharmacists, health departments, and doctors' offices. And all along, we knew we would hit this wall, that if those people weren't involved with this process, we would have not good compliance with getting the vaccine. So we were the last ones to get the vaccine, unfortunately. Has that been your experience as well? The doctors were the last ones to get the vaccine, and now do the doctors have access to it?
So that is true. So one of the things is that before it was very important that we get the vaccines into the doctor's office. Majority of the physicians are vaccinated. About 96% or so say that they're vaccinated. But it's important to get it into the offices, because I was fortunate. I was one of the people who was an early adopter. And so we go into our clinic, and that is part of the routine questions. I ask everyone, have you been vaccinated? So we give vaccines while people are in the office as well, besides going out. So it's important that you give the access to the doctors and get it into their offices so that they can vaccinate during those routine visits. For the pediatricians, doing those routine health checks, that you give them their vaccines when you go to just any other facility. So that is key, is getting it into the doctor's offices, because often your physician is your most trusted person that people have.
You bet. Thank you. Dr. Bailey, I'll go to you. Your life and my life has been centered around giving advice to patients. And we typically talk about the benefits and the risk of what we're prescribing. And, for me, it was, should you have a surgery? Should you have a C-section? For you, you prescribe treatments that can cause anaphylaxis, and you have to weigh that risk-benefit with everybody. When we started out with this process, no one worked harder than we did to make sure every American adult had the opportunity to get the vaccine. And we sat down with people over the age of 60. It was a slam dunk that the benefits outweighed the risk. Now we're talking about people under the age of 21 and the benefits of the risk of the vaccine. The risk of the virus to a person less than 21, pretty small. More and more, we're seeing some concern about complications and risk to the vaccine as well. As you advise parents or young adults, do you feel like you have the data, the science, that you can actually have a great conversation discussing the benefits and the risk of the vaccine to give them advice?
Yes, I do. These vaccines have been thoroughly studied in adolescents, and we're now studying them in children. And yes, the benefits and the risks discussion is something that definitely needs to be had. But I think there's a general misconception among the population that children are at no risk, or that the risk is so small that it's less than the risk of getting the vaccine. And that's simply not true. Children do get COVID. Children get long COVID after having COVID.
And you've seen the science side by side that would say, here's the risk of a serious complication to a person in the age of 21 versus the risk associated with this vaccine? You've seen that side by side because I've not seen it.
Well, we'll be happy to share the data that we do have, but the risks of side effects in adolescents appears to be very, very small, but we know that the risks of long COVID in children can be quite significant.
Okay. Dr. Bailey, would a T-cell test be a benefit to you as you're sitting there considering a person, a young adult especially, that's already had the virus? Would that be a benefit to you in that decision-making process?
I think it would be helpful, but we still do not have the perfect package of laboratory tests that we can run on someone to say you're immune, you're not immune.
Right, but if we had a T-cell test, it would be very helpful, I think, for most doctors in giving
It would
advice.
add to our armamentarium.
Right. Dr. Betancourt, as we watched, I assume, was that Elmo?
That was Elmo and Elmo's dad.
And Elmo's dad. You know, one of the things I noticed is that neither one of them had a mask on. And I assume there's a reason for that because kids don't trust adults with or trust people with masks on. Have you all looked into the mental impact on children by making them wear masks and the adults around them wearing masks?
Yes, actually, well, we had also PSAs on mask wearing, and particularly for children to ease that process. And also, we used our other character, Julia, who is an autistic Muppet who's 4 years old and also guided mask wearing at that time. What we do is, in this case with the PSA, it was focused on vaccine. It was indoors, and it was, again, parent-child. So the use of mask wearing in that context would not be the modeling that we would use. The focus was on the vaccination. And then lastly, also in that case with the PSAs, in transparency, with any Muppet speaking and with the mask over it, it's going to be a little harder in voicing. But regardless, in that situation, mask wearing was not necessary. But we have advocated for, again, the process of easing mask wearing when it was necessary and how to take that child's perspective to do so. But also now what we're dealing with is also how do you transition into the stages where you're not having to do mask wearing. So we're tackling both. Our focus is how do we ease transitions in a child-appropriate way.
Okay, thank you. I yield back.
Senator Casey.
Thank you, Chair Murray. I want to thank the panel for their presence here today and the message you're delivering. Just your presence and your testimony today and the answers to questions is helping to get the word out. I'll start with Dr. Nichols, and of course would open this up to others as well, but I want to talk to you about people with disabilities as a particular community. You have great personal experience with family medicine and providing healthcare access across a number of communities. One of the communities that's often neglected during not only this public health crisis but others is people with disabilities as a community. Because of their primary disability or secondary health conditions, they're often at greater risk than others. In fact, during the height of the pandemic, people with developmental disabilities such as Down syndrome had the highest mortality rate other than those 75 and older. So communicating the importance of becoming vaccinated to people with disabilities is, of course, complex. Communication methods needed to take into account, including accessible video with sign language interpretation and plain language documents so that someone needing kind of jargon-free descriptions can understand information. You mentioned, and others have as well, and we can't say it enough, meeting people where they are, as you said, in their vaccine journey. So the question I have is, how should we be communicating with this particular community, which is diverse, the disability community, ensure they receive the information that's necessary about vaccinations?
So again, thank you for the question. You hit on a great topic as far as getting to people with disabilities. One of the things is, again, through the physician's office, is to ensure that the vaccines are available in the physician's office so you can reach the disabilities. Also going into, if there are places like we go into our senior homes. So I'm going Wednesday to go and vaccinate within the senior community. So also going. We have also, I believe in making it easy as possible. Not everyone can get in a car. And so that's something that you have to do as far as going to them. That's what our mobile program is about. And also, you touched on a great area. Make sure you have the information in multiple languages. Multiple languages, also sign languages, to make sure that people understand. And that is why with the face mask, so that is a good thing, because people who are deaf they don't know what you're saying. So before, it was important to use the clear masks, but now, since most people are vaccinated that are providing the vaccines, is to make sure that you make it easy for them to read your lips, and also to have the ability to have the sign language available as well. But I think the key is going into the physician's offices, so that because they're the ones who have the direct interaction with the patients.
Mm-hmm. Anybody else on this question? The panel. I was going to move to Dr. Betancourt on children. Of course, that's your area of expertise and hesitancy. We've also seen major disparities in the vaccination rollout to date, and particularly when it comes to vulnerable children getting left behind as more children become eligible for the vaccine. We've got to address, of course, the concerns of parents who are hesitant to get their children vaccinated, and we have to do that, as you and others have talked about, through thoughtful and culturally appropriate community engagement. So what are your thoughts on how we can best engage families, particularly families that have lots of challenges, to help parents make informed decisions?
Yeah, it's a couple of things in terms of more marginalized communities, and we always address that as we're developing any of the content that we've discussed. It is two ways. One, it is looking at the other trusted sources. We've discussed a lot on terms of the medical or healthcare community in its diversity, whether it's the pediatric community, whether it's public health clinics, and making those connections. But it's also the messaging. And as we said, for younger children, it's going to be a little bit of a challenge, as we discussed. Many times that perception is that they're fine. And again, it's twisting the messaging a little bit. So how do you, again, try to leverage what we're calling a circle of care, a circle of safety in that care? How do we encourage not only the vaccination, but I think returning to a medical home? Most marginalized families and many families have been separated from their medical home. So how do we unite what we call the key influencers in young children's lives? So it's the healthcare community, it's also the early childhood community, it's the faith-based community. Our belief is to make a difference, you need to message, but similar messaging across all those groups where they are, but with similar approaches. Use social media or use posters, use a variety of elements, use audio as well, radio. We've created our PSAs so that they're available also in audio formats. We also close caption, both in terms of visual and auditory, to make sure that everything is also accessible as much as possible. And lastly, version it as much as we can into a variety of languages that are culturally relevant.
Thank you.
Thank you. Senator Paul?
Dr. Bailey, I agree with you that misinformation is leading to vaccine hesitancy, and I think probably the largest area of misinformation is actually coming from the government regarding natural immunity. There's actually dozens and dozens of peer-reviewed articles on natural immunity. The natural immunity is robust. A study from Washington University School of Medicine just recently says mild infection with SARS-CoV-2 induces a robust antigen-specific long-lived humoral immune memory in humans. Cleveland Clinic study, 50,000 employees, showed that those who had had the disease previously had the same, if not better, immunity than those who'd been vaccinated. If we deny this and we say, stick your head in the sand, everybody be vaccinated, don't worry your pretty little head about whether you've had it or not, we don't do any testing, we have lots of ways of testing for immunity, guess what? The people are going to have hesitancy because they think you're not telling them the truth, which is true. That isn't the truth. We do know that you get robust immunity from this. We also know that even taking conservative estimates from the CDC, that about 100 million people have had this. How do we know that? 34 million people have tested positive, but even the most conservative antibody surveys show that at least 2 people for every 1 that got it also had it. That's 100 million people. And so if we discount that, we say, oh, we're never getting to herd immunity. You have all these articles saying, we'll never make it, we'll never make it. We don't have enough people vaccinated, but then we say, oh, we got to go harder. Now we're going to go for the 10-year-old, then the 5-year-old, then we're going to go for the 2-year-old, then we're going to say, oh, you can't leave the hospital until you're vaccinated. People are going to be hesitant because they don't believe you, and they don't believe that the risk of the disease in children anywhere equates to adults. Over 65, it's at least 1,000 times more dangerous. The death rate under 25, about 1 in a million. If you combine natural immunity with vaccine immunity, Dr. McCary of Johns Hopkins estimates that 80 to 85% of adults have immunity, and that we have reached herd immunity. Yet the government insists on discounting or really not counting at all the millions of individuals who have acquired natural immunity. This scientific error causes the government to believe that we haven't gotten there, that we have to go harder and harder and harder. There are reports of myocarditis. It isn't decided yet. We're in the means of talking about this, and if we just say blithely, go take your vaccine, don't think about this, that's not good medicine. We should think about it. I don't know what the risk is. It may turn out that it's 1 in 10 million, and then by all means I'd say go. If you're over 65, I say without question, the vaccine is way safer than the disease. But I can't say that with a surety for a 10-year-old. I really can't say that. I also can't say that we haven't reached herd immunity and that we're pushing so hard on the kids that we might do damage to children with this. It's an unknown question. The science is not completely done on children. They're discussing it this week. How frequent is myocarditis? We don't know that. If it's 1 in 100,000 and the chance of myocarditis in the normal population is 1 in a million, I would probably say you ought to think twice about it. But another way to do it is we could test the children. We could test the adults. If they have antibodies, let them make a choice. Let them make an intelligent choice. Some people will still choose to be vaccinated. But we are so adamant, get the vaccine, don't think about it, that leads to hesitancy because people don't think we're following the science or that people who give that advice are following the science. So my question is, shouldn't previous infection be considered in the effort to push vaccination on our children?
Yes, I think previous infection should be considered. I also think that we need to understand that a previous infection is not as robust in protecting against new variants as the vaccine.
We actually don't know that. We actually don't know that. All of the testing on natural immunity and vaccinated has shown that we have great immunity both with the vaccine and with natural immunity. The Delta variant that everybody's talking about, the vaccine is very good for it. So you see hysteria on TV. We're still driving this debate by the hysteria of the Delta variant. If you get vaccinated, there's a 96% chance you won't be hospitalized. The numbers are very similar for natural immunity too. This what if has been played, but it's just not true, and we're scaring people needlessly. We should study it honestly in a rational fashion and give people advice, but we shouldn't be pushing people, don't think about it, just take a vaccine. Dr. Bailey, failure to acknowledge natural immunity has led to the policy of indiscriminate vaccination. So when we do this, we divert the vaccine from those who truly need it. In India, getting to herd immunity may take a couple of years. 6,000 people were dying a day recently. And they're taking the advice of the government experts in our country that they should vaccinate everybody indiscriminately. In doing so, tens of thousands, if not millions of Indians will die, because you're going to have millions of people who have already had it. If you could get the vaccine to those who need it more, you will save lives. It's the same way with diverting it to those over 65. In my community, in this country, we're giving it to young, healthy 28-year-old volunteer firemen. That makes no sense at all. So do you think in countries like India, we should take into account whether you've had it to try to make the vaccine go farther so we could save lives?
I can't comment on vaccine administration strategies in other countries. I do know that we need to be a good part of the global community and provide as many vaccines as we are able to make after we've taken care of our own population, which we have plenty of vaccine for.
Thank you. Senator Baldwin.
Thank you, Madam Chair. Last fall, a green bean canning plant in Wisconsin experienced a COVID-19 outbreak that killed at least 11 migrant workers. COVID outbreaks hit food processing facilities in my home state. It's hit it especially hard. And I'm increasingly concerned that many workers who often live and work in crowded settings have not been vaccinated. Dr. Nichols, can you describe the specific barriers that wage workers, particularly workers of color, face when it comes to getting vaccinated? And what should employers do to make it easier for workers, including seasonal or temporary workers, to get vaccinated?
Senator Baldwin, thank you for your question. You bring up a great point. One of the things that we are doing is going out to the migrant agricultural workers to get vaccinated. And we're taking our mobile unit out to them so that they can get vaccinated. So I think that that's one of the important things, is that partnership. So you can partner with the various companies to vaccinate their workers. We've also talked to other companies in vaccinating, like the grocery store workers, the people that work at the different organizations such as food services, and said that we are here, and if you want a partnership, we'll be willing. So that's one of the things, is that the employers need to partner with those who have the vaccine. We have an abundance of vaccines now. We're looking to put shots in people's arms. So I think that's something that we need to do, is go out to the different organizations, the different companies, so that you can get those essential workers vaccinated and make it convenient, because you have to go to them. They can't necessarily get off to come to us. So you have to go to them. And so I think that that has been the key. Thank you.
Thank you. I appreciate that response. As my colleagues on this committee know, throughout the pandemic, I have called for the Occupational Safety and Health Administration to issue an emergency temporary standard to protect our nation's workers. The Trump administration failed, didn't work on this at all. And while the Biden administration has finally issued a standard, it really doesn't protect all workers, including those in food processing. The lack of a comprehensive workplace safety standard for all of our nation's workers and lagging vaccination rates should concern us, and we really must do more. I am now going to turn to a pervasive problem of misinformation in Wisconsin. While 45% of Wisconsinites are now fully vaccinated, this figure is only 29% for Hispanic individuals in my state. One of the factors that's been cited by the Wisconsin-based group Forward Latino is, as contributing to this hesitancy, is a widespread concern that a state-issued ID is a requirement to receive the vaccine, which it is not. Dr. Nichols, how can we combat vaccine hesitancy in underserved communities, particularly when that's based on misinformation and fear, widespread rumors like this one that I described? And further, how can the federal government best support communities in addressing the vaccination disparities and other public health challenges?
Thank you for the question. I think that's a really good point. We engage the consulates, because one of the things that we found that people are most trusting of going into the place. And we actually went to the locations. So we've been going weekly to the Mexican consulate, and now we're going to others. So it's important that you go to the location, we partner with them, and you go out so that people go to a trusted entity. So that is the key, because unless they trust you, they will not come, and they will think it's a conspiracy or that there are other things that are awaiting that there. So you can't just say, come to this vaccination site. We also tell people we do not require your ID. If you're going to do the 2-shot vaccine, we're just saying that whatever name you give right now, make sure it's the same one so we can document it. But we do not require that they give ID, because that is a limiting factor for a lot of people. So we rest assured, and we make sure there are translators that are available so that they can speak the language and tell them that this is free, that this is safe, and that no one will come after you because of your status. Thank you.
Thank you.
Senator Tuberville.
Thank you. Thank you all for being here today, and I'd like to say thank you for your common sense approach. We hadn't had a lot of that up here since this pandemic. And I'll say this too, that, you know, when we've put politics into this, which it's been eat up with politics, this whole pandemic, people back in Alabama where I come from don't trust a lot of things that are going on because they don't understand, because they've been told so many different things from the CDC and everybody that works for the CDC. And it just hadn't been a common sense approach. But thank y'all for being here today and doing this. You know, we're trying to get everybody to take the vaccine. And everybody in here over 50 should have taken the shingles vaccine. Everybody in here. I hadn't taken it. I'm much over 50. And I've seen people with shingles, and my God, you know, we just keep putting it off. And that's something Americans do. They think that they're not vulnerable to something like this, but they are. Ms. Bailey, let me ask you this. Back in April, J&J, they had a 10-day pause. Now people back in Alabama ask me, Coach, why should I take this vaccine, this J&J? They stopped it. They're scared to death of it. I don't know why. Did you agree with them making the pause to that?
I believe that the pause that was taken with the J&J vaccine was a sign that our system of detecting what we call safety signals or adverse effects is working. And I think it was a serious enough issue, having blood clots in the brain, that we really needed to look very carefully at what was going on before we decided to go forward. Out of an abundance of caution, I think it was a reasonable thing to do, but I agree that it planted some seeds of hesitancy in some folks. But the fact of the matter is that all vaccines have had some reported side effects, but we have always felt that the benefits of the vaccine outweighed the risks. And the beauty is that if someone is of this certain age group that's affected by the J&J vaccine issue with blood clots, especially women of a certain age group, they've got choices. The mRNA vaccines are not associated with those types of blood clots. And so if someone is concerned about that particular vaccine, they have a couple of great choices.
In Alabama, we've only had 30% of the people that are fully vaccinated. And one reason why we got hammered early with COVID, a lot of people had it. But they see all this information on television. You know, if you've had it, you know, you really don't need the vaccine. What would you tell these people?
Well, I tell them that they do need the vaccine because I'm a belt and suspenders kind of person. I believe that COVID is a bad enough disease that it's worth doing everything you possibly can to keep from getting it and to keep from spreading it to someone else that you love, which you can do with an inapparent infection. And so I believe people, and I agree with the authorities, that people that have been diagnosed with COVID should be vaccinated. They should get the second shot if appropriate, and should do everything humanly possible to stop this pandemic in its tracks.
We're here of a booster getting ready to come out for the fall. How are we going to sell that?
Well, we'll have to kind of wait and see what happens. I think we need to have the data to show folks that it really does make enough of a difference to justify getting all these folks in to give it to them. But I certainly wouldn't do personally a big booster campaign until we had gotten the first batch of folks vaccinated in the first place. I think our emphasis should be on complete vaccination for the first time around of the general population before we start worrying too much about boosters.
Thank you. Thank you, Mr. Chairman.
Senator Hickenlooper.
First, I want to thank all of you for your, not just for your time here today, but for your efforts and your public service in this. This has got to be one of the hardest things that we as a country have gone through, going back all the way probably to the Second World War. I was in Aurora, Colorado last week with Secretary Becerra, Senator Bennett, Governor Polis, members of the entire congressional delegation, and looking at these same issues that you're getting questions on and asking. And we were getting a tour of a bus, as you guys have described, but a bus that goes to those communities that were having the most trouble getting people vaccinated. And I think Maybe I'll start with Dr. Nichols, if that's all right. I think it's critical that what we've learned about the health disparities from this pandemic, that we use that to better inform our healthcare efforts to communities of color and any community where we see these inequities. And you talked a little bit about robust public education as being part of the major lesson learned. How can we at a federal level boost public health education efforts starting now so that we can, what specifically should you be telling us to make sure we're ready for the next pandemic, which, whether we like it or not, we know is going to come?
Thank you for the question. So one of the things that we really can do to boost this through public education is to do targeted campaigns. There are a lot of lessons learned, and we need to let people know that these are the lessons learned from this pandemic, because there might be another one. There most likely will be. And so with that in place, then what we need to do is say lessons learned is one, is that as soon as any type of virus or infection hits us, that you hit it hard and you hit it fast and you hit it as soon as it occurs. Number two, that one of the things that you need to do is that meet people where they are. And I keep saying you can't politicize this. This is an effort that is affecting all of us. It doesn't matter if you're Republican, Democrat, or independent. This is or black or brown or whatever. This is something that has affected all of us. And so what we want to do is to say our goal as a nation is to protect our citizens. And so that's what I think we need to get out there, is the importance of protecting our citizens and getting people, meeting them where they are, and educating them through every avenue possible and in every language. Thank you.
Great. And Mr. Chang, I'll ask you just to comment on that as well, just from the outside of government. Obviously, and there's, I think, a significant amount of evidence that it's not politics that are as a major reason why many of the people are choosing not to be vaccinated. It is more in that framework of their own autonomy and who they do trust. You want to, if you maybe address that in terms of preparing for the next pandemic?
I think one of the things that the federal government should think about and putting in its toolkit to prepare for the next pandemic is to develop a roster of trusted faith leaders that they can convene very quickly and early on to bring them together to have a unified message. If you look at what happened with white evangelicals, what happened was individual leaders had to take the decision at different times to speak out on this, and then they got slammed by the opposition. So Franklin Graham did that, got killed on social media. He withdrew and went quiet for a while. J.D. Greer, the former president of the Southern Baptist Convention, then stepped up. He got slammed on social media. So this was one by one. They were coming forward, and all of you know what that's like to be the lone target out there. And so if the federal government had enough foresight to actually do the convening work of bringing leaders together, because unfortunately the evangelical church does not convene itself very easily. It's a very, by design, a sort of decentralized movement. So it requires an outside body like the federal government to convene these folks together, let them present a united front. They were there, they just couldn't bring themselves together to form a united voice. They needed the government to help them.
Absolutely. I think it's a good point. Dr. Bailey, the numbers from United Kingdom on the Delta variant are obviously very concerning to all of us. That now accounts for 90% of new infections there, and obviously whether it's 10% or 15% now in the United States, who knows how rapidly that's going to grow. Clearly it's going to spread rapidly. Given our current rate of vaccination, do you think that we will get to a similar impact from the Delta variation, similar to what we're seeing in Great Britain?
I certainly hope not. We have been in a foot race with variants from the very beginning. And right now, I think we are outpacing them because we have had good vaccine uptake. But I think it's important to understand that the vaccine strategy in the UK was very different in the vaccine strategy there. And the UK decided to delay the second vaccine in patients in order to get the first vaccine in as many people as possible. And we realize now that that's not the best way to fight variants, that you need to get as many people vaccinated on time with both doses if that's the vaccine that you're dealing with, which is the best way to fight the variants. So I think we're better prepared to fight the variants.
Great. Well, I appreciate that. I hope you're right. I yield back. Thank you all.
Thank you. Senator Smith.
Thank you so much, Chair Murray and Ranking Member Burr. I really appreciate this hearing. It gives us all an opportunity to kind of dive into where people are on the spectrum of acceptance versus I'm not really sure to sort of a hell no mentality. As of yesterday, 54% of Minnesotans have received at least one dose of COVID-19. 51% have been fully vaccinated, and we're making good progress in Minnesota, but we've got a ways to go to get to where the governor has set as our goal in the state of 70%. So I have a few questions that I hope can kind of clarify some of the misinformation that is out there and also help us understand what more we need to do. Let me just start, if you don't mind, Dr. Bailey, I just want to start with you because Senator Paul interrupted your comments regarding the efficacy of the vaccines compared to immunity when people are exposed to a new variant like the Delta variant. And I just wanted to give you an opportunity to finish your thought.
Oh, well, thank you, Senator. I appreciate that. My interpretation of the literature, and it is vast, and there are so many thousands of studies that are available now for review. We've got to be able to put them together. But my understanding is that adequate vaccination with both mRNA vaccines or the Johnson & Johnson vaccine gives you better protection against variants than natural immunity does.
Okay. All right. Thank you. And so the COVID-19 vaccines do protect against the Delta variant is what the science tells us right now.
Yes.
Okay. Thank you. That's very helpful. Dr. Nichols, can you just quickly sort of say, what do you think are the biggest structural barriers? Meaning there's reasons that people don't get the vaccine, not because they don't want to, but just because they can't make their lives work to get the vaccine. What are the biggest structural barriers?
So transportation is one. So that's why I say it's important to go where people are.
Right.
The other one is hours. Some people work 2-3 jobs.
Right.
So you have to make sure that the availability is there at all hours. And I really appreciate now the pharmacies and some of the grocery stores are extending those hours for up to 24 hours.
Yep.
So you have to make sure that those are the main ones. Also, before, structural barriers happen to be internet and computers. So that's why it's important to make sure that when people were making appointments that you made it easy. So now people don't have to make an appointment. You can just walk up. And so I think that those are things that we are seeing are true that were barriers before that we're helping overcome. But the main thing is making sure that you are there and make it very, very convenient for everyone.
You're going where people are. You're not assuming that everybody has the wherewithal if they're working 3 jobs to get someplace. What do you hear are the kind of the most common myths, just the flat out not true but get repeated that you hear about why people are thinking why not get the vaccine? The most.
So my young people, my early 20-something people, a lot of them are talking about infertility.
Yeah.
And I tell them that is absolute. That does not go with the science. That is a very common one. That's probably the most common. Another one is the myth that people said, oh, I already had COVID-19, so therefore I don't need to be vaccinated. But there are people getting COVID for the second time around, and there's variants out there. So those are the really big 2 myths. And then the whole thing with Johnson & Johnson, people say, remember talc powder. So I have to then remind them that this is a very safe vaccine, that this is a vaccine that has gone through all the rigors and the science everywhere else. So I just hit them with the facts and the data and the science.
Very helpful. Dr. Bailey, are there other myths that you have heard repeated frequently that are different from what Dr. Nichols just laid out?
There's a common, almost an existential concern that something that we don't know about is going to happen down the road. That, well, how do I know that if I get this vaccine today that something's not going to happen to me in 5 or 10 years? We have decades of experience with dozens of different types of vaccines, and we have never seen a vaccine cause a distant side effect past about 6 weeks of administration. So we feel very comfortable about that. There's no reason why why COVID vaccines should be any different. But granted, the farther you are from getting the vaccine, it's going to be to correlate an event to that vaccine. But so many events that have been reported are coincidences and not causal. And it's hard to explain to folks that just because something happened near the time of the event doesn't mean the vaccine made it happen.
And I know I'm out of time, but is that data essentially also true when you're talking about vaccines for young people as well as older people? So it's not like there's some sort of a different set of data for a young person.
That is true, Senator.
I think that's very helpful, just to remind people that we do have science and facts and data that back up what we're doing, and it's good to help to, speak out against these myths that get repeated over and over again. Thank you. Thank you, Senator.
Senator Murphy.
Thank you very much, Madam Chair. Thank you all for your testimony. I've been listening to a lot of it from my office. Dr. Nichols, I had a really interesting conversation yesterday. I put it up on my social media channels with the student body president at the University of Connecticut talking about the specific challenges around vaccinating students. And I wanted to sort of ask for your opinion about how we build out best practices to make sure that college students are ready to get back to school in the fall. Data suggests that less than 40% of 18 to 29-year-olds have received one or more doses, and there seems to be some differences with respect to how colleges are sort of treating this issue. In Connecticut, for instance, our flagship university says everybody has to be vaccinated and have proof of vaccination in by the end of July, but our state university systems haven't made a decision yet. And so it's confusing to students because some may have a requirement to get a vaccine, but other students may not. In addition, the requirement seems to be that a lot of the proof come in during the summer, which means students may not get to do this while they're on campus. I know you've been leading a lot of Morehouse's efforts in this regard. What do we know about the specific challenges related to getting students vaccinated, and what can we recommend as a committee to schools and to school associations to make sure that there is some degree of uniformity in terms of what we expect of kids to get back onto campus?
So thank you for the question. So it's very important that we again provide the data and the information to the students and to the administrators on vaccines. Also doing town halls and panels. I have one coming up on Thursday where you talk to the parents of the students about vaccine safety. Right now, over 500 colleges and universities have made it mandatory. I personally think that is the right thing, but not everyone is ready to get vaccinated. And there are ways, some people have religious reasons that they feel that they can't be vaccinated. Other people are medical reasons. So you do give that options. But I think the important thing is to talk about so you can get back to normalcy. Many of the people that are now college-age kids, they didn't have a normal experience. They weren't able to have proms if they were in high school, or even to have normal graduations. So I think that one of the things that you have to explain to that age group, which is a very difficult group to talk to, is because they're young and they think they're invincible. So it's to say that this is your opportunity to get back to normalcy, not to wear a face mask, to be able to get out towards your friends, but also to give them the data, because these are college kids. So to make sure that they have the data and the science to show that the safety and the rigors that were involved with this vaccination process. So I think that we're on the right path, but I think that we as an institution must talk to all the colleges at the administrative level, to the parents of those students, and to the students themselves. Thank you.
Just food for thought, one of the things that the student body president wanted to make clear is that there needs to be safe space for questions to get answered. Sometimes there's a feeling that students are maybe going to be looked down upon when they sort of ask some basic questions about the vaccine. They're always a little careful, right, in not wanting to sort of look foolish or look like they aren't as plugged in. We need to make sure that nobody feels bad about asking questions because we have answers. That's the good news.
I tell everyone there's never a stupid question. So I always tell the students, I really want you to ask those questions, and we need to answer it in ways that can relate to them. And social media is very important in that age range as well.
I know we have a bunch of people that want to ask questions, and we're going to have votes. So I'm just going to submit a question for the record to you, Dr. Bailey. I'm really interested in some of the comments you made in your opening statement about the dangers of misinformation, and I'm working on legislation right now with the American Medical Association that would set up an interagency effort housed within the U.S. Department of Health and Human Services to try to bring together both government agencies, think tanks, academic institutions to both track and evaluate misinformation. Sometimes it's difficult to sort of know what to label as misinformation. And I'd look forward to working with you and others as we try to work through that legislation. Great. Thank you.
Thank you. Senator Kane.
Thank you, Chair Murray, and thanks to the witnesses. This is fascinating. A couple of quick research questions. So as I'm trying to make the case to my constituents to get vaccinated, and yesterday our governor announced that Virginia has just crossed the 70% mark on at least one vaccination, which is great. I point out it's effective in stopping COVID if you haven't had it, but there's also two other benefits that I cite based on some initial studies, but I wonder if I'm on solid ground in talking about this. The vaccine isn't 100% effective, so someone can get the vaccine and still get COVID, but it does seem like that there's some evidence that if you've been vaccinated and you get COVID, your symptoms might be lesser. Is that a fair statement of kind of early evidence that's emerging when people get vaccinated and then get COVID? It tends to be less serious cases.
That is true. And people who are vaccinated are very unlikely to be hospitalized, and in some situations, it prevents death entirely.
That's very, very powerful because obviously I had COVID, I wasn't hospitalized. The difference between not being hospitalized and being hospitalized on a ventilator, serious issues is very stark. So that's a good piece of evidence for being vaccinated. Second, there's also some suggestion that people who have had COVID and are suffering long COVID symptoms, which might be 15 to 20% of people who get COVID. There's some, again, articles suggesting that some of the long COVID symptoms disappear upon vaccination. And again, I've seen that reported in media. I don't know if there's been enough research on it to kind of validate it, but what is the current state of play on that?
Senator, I've heard the same things that you have, and there have been some case reports of patients with long COVID whose symptoms have improved after vaccination. That is still under study. We don't really know enough about long COVID itself to understand what makes it better or what makes it worse. But the few case reports are encouraging.
That is also positive. So I think there's multiple reasons to get it. Dr. Bailey, I have focused some significant attention upon vaccination of pregnant women and wanted to make sure, A, that it's safe, B, that they have access, and that there's an effective take-up rate among vaccines. So what are you able to tell us, again, based upon kind of the initial experience, and I'll open this up to anyone, about the safety of receiving COVID-19 vaccinations during pregnancy?
There were a number of women in the clinical trials who became pregnant after they had received the COVID vaccine and did well. There was one pregnancy loss, but that turned out to be in the placebo group, not among the group that received vaccines. The American College of Obstetricians and Gynecologists now recommends that pregnant women get the vaccine. We know that pregnancy is a somewhat immunocompromised state in and of itself, and pregnant women are susceptible to more severe disease if they contract COVID-19. So we believe it's important to immunize pregnant women, and those antibodies will transfer to the baby, and so the baby will have some degree of protection as well.
Excellent. Thank you. Mr. Chang, I found your testimony fascinating. I read the written version of it because I was not here during your opening. I was at an Armed Services Committee hearing, and you point out that a path to greater vaccination is through the white evangelical church. You have two kind of recommendations, one of which just seems unassailable. Find trusted leaders, evangelical leaders, and gather them together so that when there are messages about vaccination, people are hearing them from the folks that they most trust. And I think you've all sort of testified to this. You got to meet people where they are rather than expect people to come to where you are. So whether that's outreach to minority communities, evangelical communities, that sounds like a really good strategy. But the other sort of half of what you said is that sort of a mistrust or among evangelicals for sort of governmental authority. And over the course of my public life, that's puzzled me. I had a pivotal experience of living in a military dictatorship in Honduras when I was, young, 1983, 1984. So I guess I saw what a really bad government can do. And it gave me a perspective that, our government here, our small d democracy, certainly isn't perfect. But I see how it is elsewhere. So while I've never hesitated to criticize authority, I have a sort of deep appreciation for how lucky we have it compared to elsewhere. What are strategies that we ought to be embracing to try to bring down that mistrust? In addition to using trusted messengers, what are things that we as officials could do to start to tear down slowly that mistrust?
That's a great question. And I think one of the things that I've been trying to do is to actually teach my fellow Christians that institutions are people too, that institutions are comprised of people, that they're human. These are human institutions, and therefore they are going to be flawed. And I think part of the problem is for evangelical Christians is we're in some ways hyper-individualistic. It's partly built into our faith. It's sort of me and God.
Mm-hmm. Personal relationship.
Personal relationship. And the idea that actually also human beings also comprise institutions is something that isn't very strongly taught in the evangelical community. But it's critical, because if we don't think of institutions as human, then when they do change their mind, we think that institutions cannot be trusted. Whereas we're okay with individuals changing their mind, we somehow are not okay with institutions changing their mind. And a lot of when we say, well, I'm hearing so many different things from the CDC, it's because the CDC is made up of scientists who are human beings, who are responding to new information and new data and are changing their mind and may not get it right from the first time. So I think certainly within the evangelical community, to humanize institutions is critical. And then from the vantage point of public institutions, the more you can present a human face behind the institutions, the more that I think that sense of humanity can come through.
Thank you very much. Thanks, Chair Murray.
Thank you. Senator Braun.
Thank you, Madam Chair. My first question will be for Dr. Betancourt. Back in Indiana recently, Indiana University, flagship institution, required students and faculty to be vaccinated before they could return. I got a simple question. Do you believe that American citizens have a right to privacy about their own health care?
I would think so, absolutely. And from a Sesame Workshop point of view, we do focus on our youngest children and the grown-ups who make decisions for them. And we know that in terms of privacy that's extremely relevant to their questions and also their information gathering.
So do you think that would also apply to adult college students and faculty as well?
From a Sesame Workshop point of view, I would say that's a little higher. But I would say that our experiences many times on what applies to young parents making decisions about their children also applies to, again, older college-age students or youth.
So and to zero in on then, do you think that you need to have a proof of vaccination as a condition for enrollment?
That is beyond, I'm going to be honest, that's going to be beyond our Sesame Workshop decision making. Our focus is basically how do we promote the awareness of vaccination as being something for not only in the moment, but also for your future. So what I would take into context is that college students come from families. And our message is that as a family, you're making a decision for safety, for also hopefulness for the future, and that there's advantages if you do that holistically, regardless of whether you're a college student or you're an essential worker or anything like that. So our messaging is more in that context, and hopefully it's creating what we've often called that circle of care.
Thank you. Next question is for Dr. Bailey. Clearly, I think the biggest variable that's gotten this in the rearview mirror was the speed at which the vaccine was developed. I remember interviewing Dr. Fauci and Dr. Collins and Redfield back then, and there was kind of a wrestling match in terms of which bureaucracy was going to lead the dynamic. I think had that gone according to normal procedure, we could still be wrestling with having that vaccination being done. And it was a tribute to the entrepreneurialism of the industry and the agility, I think, of the administration at the time. So do you think that when it comes to something as simple as trying to get people comfortable with vaccinations, that maybe time spent better by the Biden administration to where it would have educated folks on the vaccine instead of still weighing in on mandates and shutdowns and things maybe not directly related to what was going to probably be the only thing close to a silver bullet of getting this in the rearview mirror? Did we waste time?
That's a difficult question to answer. And I do believe that one of the issues that my patients have concern with is that they feel that the vaccine was rushed, that it was made too quickly. They need more information about that. And I always take great pains to explain to them that, the beauty of Operation Warp Speed was that no corners were cut, no scientific rigor was left on the table, that the companies were given the financial security to be able to do this very quickly because there were a whole lot of real smart people and a lot of money involved, and they were able to get it done in an amazingly short period of time. We can never stop talking about the importance of reviewing vaccine safety and efficacy, and how these vaccines have gone through incredible clinical testing, and is, I think, one of the greatest scientific achievements in our lifetime.
Well, very good. I think that's well said. How about going forward? We're seeing now variants. Watched something over the weekend where they were talking about using mRNA technology to maybe apply it towards fighting cancer in a particular way, and also to where it might end up playing into going about contriving, creating therapeutics versus just vaccinations, because it looks like this could be repeating itself through variants, maybe get to where it's in a rhythm similar to how we wrestle with the common flu. Where does emphasis on therapeutics fit in to the long-term journey of how we deal with and live with the coronavirus?
I believe that that's an incredibly important area to pursue, because I think all of us acknowledge that although we want to get as many people vaccinated as possible to get past the pandemic, that COVID is probably always going to be with us in some way, shape, or form. And we need to learn better how to treat COVID at early stages to keep it from progressing to hospitalization and death in someone that hasn't been immunized or in a new variant that may be resistant to vaccination. And mRNA technology in and of itself is absolutely mind-boggling in its potential across all specialties of medicine. And so I think that it's important for us to make sure that we continue to focus on research for therapeutics, research for diagnosis, research for care, for vaccination, and for long-term complications.
It's good to hear that you think that might make sense, because it seems like that's going to have to play into the formula in the long run. Thank you.
Thank you. Senator Burr, do you have any additional comments?
Just two quick ones, Madam Chairman. So, Dr. Bailey, if a patient diagnosed with pancreatic cancer was provided a cure delivered on a mRNA platform today, you think they'd be as reluctant to take it as they are a vaccine on an mRNA platform?
I'm not a cancer specialist, but my experience is that when patients are really desperate for help, they will take risks that they might not take otherwise.
Isn't part of the problem that we've got is that some people believe that this isn't as bad as what we've suggested?
the disease of COVID is not as bad as we've suggested. I worry about that going forward as the huge numbers of hospitalizations and deaths seem to fade into the rearview mirror, that we'll have some collective amnesia about how bad it really was. COVID-19 infection is a devastating disease. It is a tricky virus unlike anything we have ever seen before, and we must never underestimate its potential to wreak havoc and cause death. And I think that, someone who still doubts the existence of COVID, we need to put them in. Hopefully, I wish we had time travel so they could go back and safely walk through a hospital ward where every patient was on a ventilator. They were unable to speak to their loved ones and had to say their goodbyes over an iPad, surrounded by people that they couldn't see because they had so much PPE on. I hope we never have anything like this again, and we must always remain vigilant to make it so.
We would agree with you, and I think if you could take everything that the committee members have said throughout this process and sort of add them together, it would have addressed the mental health for children, it would have addressed the physical challenges that are presented, the employment challenges, the society challenges. Hopefully our memories won't be as short as we have proven in the past. Last thing, I've said to the administration, because I think we're destined for a booster based upon the science. When, nobody knows. But I have made it perfectly clear that we better have a strategy when we get ready for the booster period, meaning that we're out selling it long before we started. I agree with you. We ought to inoculate as many folks as we possibly can in the first round, but you can't start too early at educating what that booster can mean based upon what we don't know, not necessarily based upon what we do know. And it may be that all 3 vaccines that are currently approved are sufficient for Delta. Does it mean it's sufficient for what we're seeing in South America today? And I can't remember what the name that we're calling it, but it is devastating South America. So the one thing we know about viruses, they continue to mutate. As long as they exist, this one will continue to do it. And if the booster provides us a better defense, then I hope we will sell it so that the American people will aggressively take it. Thank you, Madam Chairman.
Thank you, Senator Burr. Well stated. That will end our hearing today, and I do want to thank all of my colleagues for such a thoughtful discussion, and I want to really thank all of our witnesses today, Dr. Bailey, Dr. Nichols, Dr. Chang, Dr. Betancourt, thank you, Mr. Chang, Dr. Betancourt, thank you so much for sharing your experience and expertise. It was very, very helpful. For any senators who wish to ask additional questions for the record will be due in 10 business days, July 7th, 5 p.m. The hearing record will remain open until then for members who wish to submit additional materials for the record. With that, the committee stands adjourned.
Thank you.